diseases, and second is carcinoma, because carcinoma is a big topic. Now, we have to go through esophageal anatomy, presentation of benign esophageal disorders, perforation of the esophagus, structural lesions of the esophagus, esophagitis, and very important GERD and motility disorders. Now, esophagus is a muscular tube. You can well see in this diagram that it is 25 centimeter in length, measures from its origin in the neck just below the cricoid cartilage. But if we will measure from the incisor teeth, then it is 40 centimeter. Now, what are the symptoms of the benign esophageal disease? Very important symptoms, because esophagus on clinical examination we are unable to see, we are unable to examine. Now, we have most of the time for the diagnosis depend on the symptoms. These are the dysphagia, heartburn, chest pain, belching, extraesophageal symptoms. Primarily these are associated with the GERD, and patient may have problem related with the ENT or lungs related. And then you have a globus. What is globus? Globus is something obstructing in the retrosternal area. That is कि जी मरीज कहेगा कि मुझे कोई चीज़ फंस गई है. Then halitosis, bad smell in the mouth, laryngopharyngeal reflux. जब भी आपने खाना खाया कुछ ना कुछ reflux हुआ. Patient may develop asthma, cough, sore throat, and hoarseness of the voice. Now, how you evaluate the benign esophageal disease? As I told you, on examination you won't be able to palpate this esophagus, so you have to be dependent on the investigation. So the barium swallow, that is barium esophagogram, is very important. Then upper GI endoscopy, that is esophagogastroendoscopy, is very important tool for the diagnosis. Modified barium swallow, esophageal manometry, and then the pH studies. Now, esophageal manometry and pH studies are important for the benign diseases more. Now, if we take the perforation of the esophagus as a first, now it's a potentially lethal complication due to mediastinitis, because esophagus is a part of the mediastinum. So, patient may go into septic shock. Now, there are different causes of perforation, but most common cause is the iatrogenic. Now, how iatrogenic? Even we, a surgeon, endoscopist, can have perforation of the esophagus during endoscopy. So, the symptom will be the surgical emphysema. Surgical emphysema means air in the subcutaneous tissue at the level of the shoulder, neck, that is the surgical emphysema. Now, treatment is very urgent, conservative or surgical, but require specialized care. Now, what are the causes of the perforation? Apart from the iatrogenic perforation, barotrauma, for example, patient is having closed glottis and cough, then there will be barotrauma. There is a pressure change in the esophagus resulting into the perforation at the weak area. Pathological perforation, patient may have tumor which may get perforated, patient may have ulcer which may get perforated, or penetrating injuries resulting into the perforation of the esophagus. Instrumental perforation, as I told, it's an iatrogenic. Then foreign body, any foreign body which children can have or swallow accidentally or incidentally, or in psychological patients, so foreign body ingestion resulting into the perforation. Now, barotrauma is very important, and this is known as Boravic's syndrome. Now, what is Boravic's syndrome? It is a spontaneous perforation because of the pressure gradient. Occurs classically when a person vomits against a closed glottis. So, pressure in the esophagus increases and it bursts at its weakest point. And where is the weakest point? In the lower third. So, Boravic's syndrome is most serious type of perforation. Why? Because there is a large volume present in the esophagus, causes rapid chemical irritation of the pleura and mediastinum, and resulting into the mediastinitis, that is infection. And what will be the history in these cases? There is a severe pain in the chest following a meal or bout of drinking associated with shortness of breath. So, diagnosis can be suspected from the history or clinical features, and when you do the chest X-ray, there will be air in the mediastinum, pleura or peritoneum. So, it's a very clear diagnosis of the Borowiec's syndrome. Now, instrumental perforation, most common cause of perforation. Perforation can occur in the pharynx or esophagus at the site of pathology when endoscope is passed blindly. That's why many people still say first you have to do the barium swallow to see the roadmap, where is the obstruction, and then perform the endoscopy. So perforation may follow biopsy of a malignant tumor also. Patient undergoing therapeutic endoscopy have a risk 10 times greater than diagnostic endoscopy. So therapeutic endoscopy means you are trying to take the biopsy, you are trying to dilate the stricture, you are trying to put the stent. So in these cases there is a 10 times greater risk. Diagnosis is by the history and the examination. If not diagnosed immediately, then it should be assessed with water soluble contrast swallow. Now you see, barium is not a water soluble contrast. It is the gastrographin which is water soluble. Why barium is not indicated? Because barium is a bit irritant for the mediastinum. So if there is a perforation, it will cause more mediastinitis. If negative, then dilute barium. Now first you have to do gastrographin, and if it is negative, you won't be able to see their perforation, then you can perform barium swallow with a dilute barium. So CT scan can be used alternatively. So in the negative gastrographin and thin diluted barium swallow, you can go for the CT scan also. Now treatment of perforation, aim is to limit the mediastinal contamination and prevent or deal with the infection, and then to decide whether you want operation or you continue non-operative management. So it depends on the site of the perforation, event which is causing perforation, underlying pathology, that is benign or malignant, and then the status of the esophagus before perforation. Now by looking at these 4 factors, you decide whether you can go for the operation right now or you want to continue the non-operative management. So factors that favor non-operative management means when there is a small septic load, minimal cardiovascular upset, perforation confined to the mediastinum, perforation by the flexible endoscope, or perforation of the cervical esophagus. But factors that favor operative repair, when there is a high septic load, when there is a very high amount of the food in this esophagus, when patient is going into the septic shock, when there is a pleura breach, that is pneumothorax, then Borowiec's syndrome or perforation of the abdominal esophagus. When there is a perforation of the abdominal part of the esophagus, there will be peritonitis. So barotrauma Borowiec's syndrome, for patient requiring surgery, direct repair is preferred if perforation is recognized within 4 to 6 hours. Now you see, this is very important. If patient is reaching to you within 4 to 6 hours, you can directly repair that perforation. But after 12 hours, tissues become friable. There will be swelling, edema, and if you stitch that area, there will be cut through. So you won't be able to repair that perforation. The hole in the mucosa is always bigger than in the muscle, so muscle should be properly incised. In patients with delayed presentation and widespread contamination, aim should be to achieve wide drainage. You have to put the drain with creation of the controlled fistula and distal enteral feeding. So that is the conservative management. You take this esophageal perforation as an esophageal fistula. Now what is Mallory-Weiss syndrome? Very commonly comes in your BCQs also. It is the forceful vomiting which produces a mucosal tear at the cardia. Now see, in Borowiec's syndrome there will be full blown perforation, but here forceful vomiting resulting into the mucosal tear. Now because of the vigorous vomiting, there is a vertical split in the gastric mucosa immediately below the squamocolumnar junction. present with the hematmesis. Now because mucosa, submucosa contain the blood vessels, so patient present with the hematmesis. Usually bleeding is not severe, but endoscopic injection therapy may be required. So in these cases, most of the patients respond to your conservative management, so surgery is rarely required, and symptoms usually resolve in 7 to 14 days. Now what are the structural lesions of the esophagus? That is associated with anatomical narrowing, presenting with dysphagia. Now when luminal diameter is less than 13 millimeter, patient will be having the obstruction of the esophagus. It could be hiatal hernia or paraesophageal hernia. It could be because of the congenital rings, webs, food impaction, foreign bodies, or diverticulum. So you just remember the name, that is Chicharsky ring. 4% on endoscopy you can diagnose this. Most of the time it is undiagnosed, so there is a thin membrane at the squamo-columnar junction. It is only composed of mucosa and submucosa. It is usually congenital, sometimes it may be acquired, and it is asymptomatic, but patient may present with the symptoms of the GERD. Symptomatic when diameter of the esophagus is less than 13 millimeter and passage of the single bougie or balloon dilator is sufficient for the patient to get rid of the symptoms. So it means esophageal dilatation is the answer for this treatment. Esophageal waves, these are commonly in the cervical part of the esophagus. Most of the time these are the developmental anomalies. Rarely they are completely encircling the lumen. Most of the time they have half circle involvement. Best demonstrate on esophagogram with lateral view. You can well see in this X-ray also. Causes dysphagia for solids when symptomatic, respond well to the bougies of the esophagus, that is the esophageal dilatation. Plummer-Vinson syndrome, very important syndrome, you must remember because BCQ may come from this. It is characterized of three things, that is presence of the cervical esophageal webs, patient will be having dysphagia, and resulting into iron deficiency anemia. So whenever patient who's having iron deficiency anemia and also difficulty in swallowing, you must think about the cervical esophageal webs, and when you will do the endoscopy or esophagogram, you can diagnose. It is primarily in the woman associated with the celiac disease, but what is important with the Plummer-Vinson syndrome, it is pre-malignant condition. So you have to diagnose it, otherwise it will convert into squamous cell carcinoma. So correction of the iron deficiency may result in complete resolution of the dysphagia and disappearance of the wave. So if you diagnose early, you can prevent this cause of the squamous carcinoma. Zenker's diverticulum, this is the outpouching or herniation of the mucosa and submucosa at the Keelan's dehiscence. Now what is Keelan's dehiscence or Keelan's area? This is basically the area of weakness in the posterior wall of the hypopharynx, just above the cricopharyngeus muscles. So may result from the poor distensibility of the upper esophageal sphincter muscle caused by the fibrosis. Over time, high pressure forces more of the mucosa to herniate through the Keelan's dehiscence, and there is a formation of the diverticulum. Now what are the symptoms? Very typical symptom, that is you can listen the gurgling sound in the neck. Now see, this is very important. Somebody says, I can well listen the movement of the intestine कि मुझे आवाज़ें अपने neck में आ रही हैं, and then there will be a regurgitation of the undigested food, and patient will be having bad smell in the mouth, that is halitosis. And sometimes in thin neck you can see the visible lump on the side of the neck. Now if you press that lump, patient will be having regurgitation of the undigested food, which is a very confirmatory diagnosis of the Zenker's diverticulum. Large diverticula can push on the esophagus and cause the dysphagia also. So diagnostic studies is upper GI endoscopy or barium swallow, and treatment is surgical or endoscopy. It means you have to remove that diverticula, that is diverticulectomy. Now you can do diverticulectomy open with the incision, or endoscopically you can clip that diverticula. So should also have cricopharyngeal myotomy to prevent recurrence. Now epiphrenic diverticulum arises from the distal esophagus, commonly associated with underlying spastic esophageal motility disorders, and they can increase its size, resulting in food retention and regurgitation. Again, treatment is surgical. You have to excise the diverticula, and of course if it is because of the motility disorder, you have to treat the motility disorder also. Now esophagitis, the most common problem in our part of the world nowadays, and you see there is a GERD. What is the GERD? It is gastroesophageal reflux disease, and it is most of the time related with taking of so many medicines, analgesics, NSAIDs, pills, medication related, caustic ingestion, acids, alkalis, causing severe esophagitis with long stricture. If patient is having some malignancy and getting radiations, so post-radiation esophagitis, usually mediastinal part, infections, many viral infections, cytomegalovirus, herpes simplex, HIV, candida fungal, or if patient who's having for example kidney recipient graft versus host disease, and patient is on many immunosuppressant drugs, may develop esophagitis, eosinophilic esophagitis because of worm infestations, and so on. So in these esophagitis, the commonest is the GERD. So what is GERD? Montreal classification defines GERD as a condition that develops when reflux of stomach contents causes troublesome symptoms or complication. Now see, stomach is used to that acidic contents, but esophagus is not used to that acidic contents. So there is a difference of the pH. Now when gastric contents come in contact with the esophageal mucosa, patient will be having esophagitis. So Montreal Working Group defined heartburn as a troublesome if symptoms occurs 2 or more days per week. Now see, it is very important. For example, if patient is saying कि मुझे हफ्ते में 2 या 3 दफ़ा जो है वो इस तरह esophagitis होता है, or moderate to severe symptoms occurs more than 1 day a week, usually this is for more than 6 months. So the history is कि मुझे हफ्ते में 1 दफ़ा बहुत ज़्यादा esophagitis होता है, या mild to moderate 2 से 3 दफ़ा हफ्ते में होता है. GERD prevalence of 10 to 20% in the Western world, and over $1 billion they are spending on these PPIs or proton pump inhibitors. Now what is the pathophysiology of the GERD? Why GERD occurs in some patients? Primary event is the involvement of the gastric juice from the stomach into the esophagus, which I already told you. And why it comes to the esophagus? Because of the gastroesophageal junction incompetency. So transient lower esophageal sphincter relaxation, major factor in mechanism of belching as well, vagally mediated reflux, hypotensive lower esophageal sphincter, anatomic disruption of the gastroesophageal junction, for example hiatal hernia of patient is having, obesity resulting into the reflux of the gastric contents, pregnancy, it means anything which is increasing the intra-abdominal pressure leads to the reflux of the gastric contents into the esophagus. So 30 to 50% cases of pregnancy having reflux, mechanical and hormonal. Now pathophysiology of GERD is factors which reduces the lower esophageal sphincter pressure, gastric distension, CCK enzyme, foods like fat, chocolate, alcohol, caffeine, smoking, everywhere smoking is the reason of so many problems, drugs, nitrates, progesterone, esophageal acid clearance, prolonged with esophagitis and can be prolonged with hiatal hernia, esophageal emptying, peristaltic dysfunction, intraesophageal reflux, salivation, if reduced can contribute to the GERD, esophageal sensitivity, that is non-erosive reflux disease. Now what are the GERD barrier? When gastroesophageal junction forms anti-reflux barrier dependent on the gastroesophageal junction complex, changes with gastric distension, esophageal motility, intra-abdominal pressure and gravity. Now these are very important parts. You have to understand this pathophysiology, what is the importance of gravity in this, and that's how you treat the patient. So the diagnosis of the GERD, presumptive diagnosis with typical symptoms of heartburn and regurgitation, can treat empirically with only proton pump inhibitor. Belching as a primary symptom, often not GERD related. Patients with non-cardiac chest pain suspected due to GERD should have cardiac cause excluded before GI evaluation. Now see, in many cardiac patients, if you take the history कि जी मैंने खाना खाया, उसके बाद दर्द हुआ, मुझे पसीने निकले, and then patients think that it is because of the indigestion, they take mucin or something, but resulting into the cardiac event. So you have to exclude the cardiac event in these patients. Now these studies are procedures not required to diagnose GERD in the presence of typical GERD symptoms. Barium radiographs, upper GI endoscopy, biopsy from the distal esophagus, esophageal manometry, ambulatory reflux monitoring, screening for H. pylori infection. Endoscopy recommended for patients with alarm symptoms and for screening patients at high risk for the complication. For patients who are acid suppressant dependent, especially men over age 50, repeat endoscopy not indicated for patients with Barrett's esophagus in absence of new symptoms. Now what is Barrett esophagus? Now Barrett esophagus means at the lower end of the esophagus, the mucosa, that is the columnar mucosa, changes into the squamous mucosa, that is the dysplasia. Now what is continuous monitoring? Acid sensitive catheter is placed in the esophagus and attached to a small monitoring device, and changes in the esophageal pH are recorded over an extended period. You can look at the pH monitoring. And then the pharmacological management of the GERD is very, very important. In every case, you don't need surgery. You have to treat with the antacids, that is the local neutralization of the acid by giving aluminum hydroxide, magnesium hydroxide, calcium carbonate. So means these are the alkaline materials, that is Gaviscon, which can simply counteract the acid production. Then second line is the H2 receptor antagonist, that is cimetidine, ranitidine, famotidine and so on. You have cytoprotective agents which just cover the mucosa to protect from the acid effect, that is sucralfate, misoprostol and bismuth compounds. And very, very important nowadays, and after that most of the cases can be managed without surgery. These are the proton pump inhibitors. Now proton pump inhibitors are having full effect, and patient may be free from the symptoms within 2 to 5 days. Some patients with defective proton pump may respond better to H2 receptor, but the commonest proton pump inhibitors are omeprazole, lansoprazole, esomeprazole and so on. Now you have to tell the patient that you have to manage the GERD by changing your lifestyle, by taking some medications. Now what do you mean by changing the lifestyle? You have to ask patient to decrease the weight, because in overweight patient there is an increase in intra-abdominal pressure. And then in the bed you have to elevate the head of the bed, and avoidance of meals 2 to 3 hours before bedtime, right? You have to take bedtime meal early, so that when you go for the sleep, most of the food went into the stomach and intestine and so on. Now medication, 8-week course of proton pump inhibitor is the therapy of choice for symptoms relief and healing of the erosive esophagitis. PPI therapy should be initiated at once a day, dosing before the first meal of the day. And H2 receptor blockers is safe in pregnant patients if clinically indicated. PPIs only if benefit outweighs the risk. Otherwise, you have to go for the H2 receptors in pregnancy. You have to optimize the PPI therapy, perform upper GI endoscopy to exclude non-GERD etiologies. For patients with persistent extraesophageal symptoms, assessment for other etiologies through concomitant evaluation by ENT, pulmonary or allergy specialist also. For patients with negative evaluation, would perform ambulatory reflux monitoring. Refractory patients with objective evidence of ongoing reflux as cause of symptoms should be considered for additional anti-reflux therapies that may include surgery. So it means when patient is not responding to your medicines, then you may think about the surgery or transient lower esophageal sphincter relaxation inhibitors, that is baclofen. Now what are the complications? Why should we are worried about the GERD? So one is the esophagitis. Second is very important is the Barrett esophagus. As I told you, length of the distal esophagus is covered by an abnormal looking cellular lining. Consequence of abnormal healing of erosive esophagitis associated with increased risk of developing esophageal cancer. So this is the second pre-malignant condition. First was the Plummer-Vinson syndrome, and then this Barrett esophagus is a pre-malignant. And then there are chances of development of esophageal stricture. So these are the GERD complications. Now what is the surgical treatment of GERD? A number of surgical approaches have been advocated, and whenever there are number of surgical approaches, it means nothing is ideal. So all are involved in an attempt to bolster the strength of the anti-reflux barrier. जो हमने पहले पढ़ा था, 4 पॉइंट्स बड़ी इम्पॉर्टेंट थी. The most commonly employed surgical approach is the Nissen's fundoplication. So what is Nissen's fundoplication? We have to wrap the fundus of the stomach around the lower end of the esophagus so that the lower esophageal sphincter become more strengthened. So that is known as Nissen's fundoplication. There are motility disorder. I am sorry, it's a long topic. So motility disorders depends presentation, that is dysphagia, reflux, cough, choking, oropharyngeal dysphagia, and causes are neurological, that is neuromuscular disorders, cricopharyngeal dysfunction, and disorders that affect the esophageal body. Now the common esophageal disorder, motility disorder, which you as a final year student must remember is the achalasia. Rest you have to just remember the name, that is hypertensive lower esophageal sphincter, hypertensive peristaltic disorders, nutcracker esophagus, jackhammer esophagus, that is a spastic nutcracker, distal esophageal spasm, ineffective esophageal motility, non-specific motor disorder. But the important is the achalasia. Now what is achalasia? It is the most common esophageal motor disorder. Incidence is 1.6 per 100,000 and 10 cases are prevalent in 100,000. Results from inflammation and degeneration of the neurons. Now see, there are menintic plexus in the esophageal wall where these neurons become degenerated, and these are because of the viral etiology. Loss of the inhibitory neurons in the esophagus result in increased lower esophageal sphincter pressure, and more importantly inability of the lower esophageal sphincter to relax to baseline. Now if you remember, this achalasia is as Hirschsprung's disease in the anal canal. So dysphagia mainly result of the defect in the lower esophageal sphincter relaxation. Patients sphincter will be unable to relax and give way to the food bolus downstairs. That is the achalasia. So how you manage the achalasia? There is a chart over there, you can see, but you can give smooth muscle relaxant, you can inject botulinum toxin, you can do the pneumatic dilatation by the bougies, you can do the per-oral endoscopic myotomy, you can put the esophageal stent, you can do the percutaneous gastrostomy tube, And the most common operation which we as a surgeon do is the Haller's myotomy. Now what is Haller's myotomy? It is the, let me complete this slide first. So management of achalasia, when you are thinking about the pneumatic dilatation versus Haller's myotomy. Now pneumatic dilatation protocol, Rigiflex balloon 3 centimeter at 5 psi pressure for 1 minute, followed by 8 psi pressure for 1 minute, and it is 1 to 3 weeks later 3.5 centimeter, 4 weeks later 4 centimeter. So this is, a big routine somebody has to follow. And Haller's myotomy is the operation you have to do once. It could be laparoscopically we can do, and we can do it as an open operation. So management of the achalasia pneumatic dilatation versus Haller's myotomy is still continue. Complications: perforation, pneumatic dilatation, esophageal perforation 4%, 3 perforations with 30 millimeter or 1 with 35 millimeter. 2 underwent surgery. This is actually the study which is showing the rate of the complications related with the Haller's myotomy and with the pneumatic dilatation. So in Haller's myotomy, mucosal tear in 13 out of 106 cases. GERD, increased acid exposure, similar, 15% in pneumatic dilatation and 19% and 23% in Haller's myotomy. Now what is secondary achalasia? That was the primary achalasia, and this is the secondary achalasia. Etiology is pseudoachalasia, post-fundoplication, Chagas disease, eosinophilic esophagitis, Algrove syndrome, and so on. You can see the list. So mechanical obstruction can mimic the radiographic and manometric features of gastrointestinal dysmotility. You can just read this, it's not very important. You can read this also, it's not again very important. You can